Alright, we're going to look at some review questions for orthopedic surgery. A 17-year-old high school football player presents to the ED following an injury on the field. He complains of pain in his right knee plus 10 out of 10, which came on suddenly after being tackled. Physical exam reveals mild swelling of the knee and tenderness to palpation over the medial part of the right knee. Valgus stress test is positive on clinical examination. The patient is otherwise physically unremarkable. Which of the following is the most likely site of damage in this patient? A. LCL, B. MCL, C. ACL, D. PCL, or E. Knee meniscus? All right, and the answer here, give me time to pause. Answer here is B, the medial collateral ligament. So there's two ways that you could figure this out. One, when the medial collateral ligament is damaged, you're going to have particular pain over the medial joint line of the knee. So let's say here's your knee here, and here's your patella. Your medial joint lines would be here for your right and here for your left. It looks like on this patient the right knee is swollen, so you'd want to palpate around the right knee joint line, or around the medial joint line, and then along the lateral joint line. The medial joint line corresponds to the MCL. The lateral joint line corresponds to the LCL. Now that's not a really specific test, but it does point towards where the damage is. The better test to do is this valgus stress test. You're going to do both a valgus and a varus stress test. Actually, you're going to do 4 different tests whenever there's knee, or 5 different tests whenever there's knee pain. And the tests are here. So first off, let's look at what these ligaments are, just to refresh ourselves. So we have 4 major ligaments, and those ligaments are the medial collateral ligament, which extends from the medial epicondyle of the femur to the medial condyle of the tibia. The lateral collateral ligament extends from the lateral epicondyle of the femur to the head of the fibula. Then we also have the cruciate ligaments, which are a little bit more deeper inside. You can't see them here; they're obscured. But deeper inside, you have these cruciate ligaments, and they get their name cruciate from cross, because they make a cross formation. And the one that's more anterior is the anterior cruciate ligament, and the one that's more posterior is the posterior cruciate ligament. So these are the tests that you do. The valgus stress test, which is the one we were talking about, this tests the MCL. So your MCL stabilizes your leg from going into valgus. And valgus, remember, is like knee knock, so knock knees. And so what you're doing here is you're stabilizing the knee and you're pulling the leg laterally. And it's very important to make sure you're stabilizing the knee. You don't want to be abducting at the hip. You want to be abducting at the knee. And so as you abduct, you should have, if it's a positive valgus test, you're going to have more movement, more valgus movement, abduction movement, compared to the normal leg. Now the varus stress test, this tests the LCL. So this should say LCL down here. The varus stress test, you're doing the exact opposite. So again, you're stabilizing the knee, but here you're pushing inward. So you're putting varus force on the knee, and this is testing the LCL. With the anterior and posterior drawer tests, you're testing your anterior and posterior cruciate ligaments, respectively. And all you do here is you stabilize your knee and you push the knee posteriorly. That's the anterior drawer, pull it anteriorly. That's the anterior drawer test. So it's like you're pulling a drawer out, pulling a drawer out from your chest of drawers. And then the posterior drawer test, you're pushing in. Again, you're going to have more degree of freedom if it's a lax ligament, a damaged ligament. And then the McMurray's test is something that we do to test the stability of the menisci. And what we're doing here is we're applying both valgus and varus force while we're holding our fingers over both the medial and lateral joint line. You're going to need to do both of these. And what you're feeling for is a popping. You may even actually hear it. And this is something oftentimes the patient will tell you, my knee makes this popping noise. And that's a meniscal tear. So this is the McMurray's test. So I go into this in greater detail on the knee lecture. Then the other thing that I didn't really bring up with this question was the knee dislocation. This is generally due to high energy trauma. What you're going to see here that's very, very, very different from these other tears is that you'll have a gross deformity with a knee dislocation. So that should be quite obvious when you see it when you're doing your initial exam. And with the knee dislocation, we do have a concern, like with other dislocations, for vascular insufficiency. And so we're going to want to make sure we're getting our ankle brachial indexes. Question 2. An 11-year-old boy presents with his mother. He complains of pain in his left knee and groin area. His mother says that he has been walking with a slight limp over the past week or so. On physical exam, you note that the boy is holding his left leg in a slight external rotation. He walks with a Trendelenburg gait. The boy is 5'2" and 130 pounds. His vital signs are stable. Which of the following is the most likely diagnosis in this patient? A. Developmental dysplasia of the hip. B. Slipped capital femoral epiphysis. C. Legg-Calvé-Perthes disease. D. Septic arthritis. Or E. Osgood-Schlatter disease. Okay. And the answer to this question is B. Slipped capital femoral epiphysis, or otherwise known as SCFE. So this is a young boy. He's 11 years old, which is roughly on the older, kind of on the older end to develop SCFE, but it is quite possible. But what stands out in this patient is that he is 5'2" and 130 pounds. And you should know roughly height to weight, what's normal and not normal. And 5'2" and 130 pounds for a young boy is obese. So this is an obese boy, and he's walking with a limp. And that is your classic SCFE. Now, this could be Legg-Calvé-Perthes disease. However, the fact that he's on the older end makes it more likely to be SCFE, and the fact that he's obese makes it more likely to be SCFE. However, the next test that you would do, if the question were to be which of the following is the best next diagnostic step for this patient, it would be an X-ray, a hip X-ray. Developmental dysplasia of the hip is something we see in newborns. You'll notice that when you do your Ortolani maneuvers. And then septic arthritis would be acute. You'd have a red, swollen hip, red, swollen knee. And then Osgood-Schlatter disease is only in the knee, not in the hip. Now, it's important to note that with Legg-Calvé-Perthes and slipped capital femoral epiphysis, these are both diseases in the hip, but they can refer down the groin and to the knee. So a lot of times, these patients will say, my pain is in my knee or my pain is in my groin. They may not point to their hip. So it's very important to remember, anytime you have knee pain in a child, you still have to keep in mind these two diseases that are actually diseases of the hip, because the pain can refer. So this is an X-ray of SCFE, and what we have here is literally what it says, a slipped capital femoral epiphysis. So the epiphysis is the area right next to the growth plate, and the growth plate, the physis, is the weakest part of the bone. And so that's going to be an area that can be damaged. And what you've got here is, you've got your, here's your epiphysis right here, and here's the head of the femur. And it's literally slipped. And of course, if you're getting X-rays, you want to make sure you're getting at least two views. So you'd want to have a lateral view of this as well, because we don't know exactly where this is, because this is just a two-dimensional picture. Here's another case of SCFE. So this one's a little bit less obvious. So here again, you see this very obvious line here, which is your growth plate, and then the rest of the femur, which has gotten detached. It's become slipped off of the rest of the femur, of the femoral head. Here you can see your physis right here. The right knee, or right femoral head is normal. This is developmental dysplasia of the hip. This is something that you would see in a newborn, and what makes this apparent is that the head of the femur is not communicating with the acetabulum. So the acetabulum is here and here. So here's your head of your femur, here's your acetabulum right here. You have nice communication right here, but here obviously it's pretty far out. Treatment for these kids would be a Pavlik harness most of the time. And this is Legg-Calvé-Perthes disease. Legg-Calvé-Perthes is simply necrosis, avascular necrosis of the femoral head. And we see it right here on the left-hand side. This is Osgood-Schlatter disease. We see this often in athletes, particularly athletes who are in bending or crouching positions. So in the United States, we would see that in track and field athletes, and particularly in baseball players who play the position of catcher. So Osgood-Schlatter disease is just inflammation of the tibial tubercle, and here you can see this bump, and this bump would be really painful if you were to press on it. Okay, question 3. 62-year-old man was shoveling his driveway when he slipped on a patch of ice and landed on his chest. He has been in significant pain ever since. Physical exam reveals bruising over the right lateral chest wall. Chest x-ray was obtained and shows a fracture of the 8th rib. Vitals show blood pressure of 140/95, heart rate of 100, respiratory rate of 18, temperature of 98.4, pulse oximetry of 88%. Which of the following is the best next step in the management of this patient? A, 100% oxygen via face mask. B, open reduction and internal fixation. C, hydromorphone IV. D, intercostal nerve block. E, endotracheal intubation. Okay, so we got a guy who slipped and broke a rib, and now we need to do something. And whenever you go to your next best step on the USMLE, first thing you should be thinking about are your A, B's, and C's. Is there any problem with airway, breathing, and circulation? And yes, in this case, there is. And the answer is we need to do an intercostal nerve block. Now, this patient has a problem with his pulse oximetry. Pulse oximetry should always be 93% or more. If it's ever below that, it's abnormal. We also have a pretty high respiratory rate here. And the reason that you've got both of these is because it's painful for this patient to make a nice deep breath in. And so he's making very quick, shallow breaths to breathe rather than normal deep breaths. And so his respiratory rate is high, but he's taking in little shallow breaths, and so he's not getting in enough oxygen because he's not really aerating his lungs. And that's all because of pain. Rib fractures are extremely painful. Now, if you were to give him 100% oxygen via face mask, well, yeah, you'd be giving him oxygen, but it doesn't take away the fact that this is painful. And so he'd have more oxygen to breathe, but that's not the problem. He'd be fine on room air. The problem's not that he's not getting oxygen. Well, I mean, it is. The problem's not that he doesn't have oxygen. The problem is that he can't take deep breaths. And so how are we going to fix that? Well, we could fix it with an endotracheal intubation, but that's not the best way to do it. We want to start less invasive first. And so we would start with an intercostal nerve block. Intercostal nerve blocks is really the cornerstone of therapy for rib fractures. And so with the intercostal nerve block, what you're going to do is you're going to palpate about 6 to 8 centimeters lateral to the spinal process. You'll insert a needle underneath the rib that you're blocking, roughly 0.5 centimeters. And of course, all of this is done under sterile conditions, and you're going to inject a lidocaine or bupivacaine mixture along with probably a steroid. That's going to provide long-term and short-term relief, usually about 3 to 12 hours, and you'll have to do it again. But if you know what ribs you're going for, then it's not that difficult of a procedure. But you don't want to do IV pain relief because it's not as it's inferior to the intercostal nerve block. With the intercostal nerve block, we're going right in to the source of the pain, and this is going to allow the patient to take deeper breaths in. His respiratory rate will drop, but that's okay. It'll probably drop to like 12, which is normal, and his pulse oximetry will go up. And this will be needed to be done until he doesn't have the pain that limits his oxygenation. Okay. If you have any questions about that, let me know. So this is an intercostal nerve block. Again, these lines, surgeons love to do this. This would piss me off, and if I were the patient personally. But they love to use their little Sharpies. And here you can see the lines over the spinous processes, lines over the rib, and then roughly 6 to 8 centimeters lateral to the spinous processes. And there they're going in with the injection. Okay, question 4. A 37-year-old male was seen in the ED following a motor vehicle accident. He was found on X-ray to have transverse fractures of the left tibia and fibula. Closed reduction was performed successfully, and the patient's leg was casted. 12 hours later, the patient reports a significant increase in pain in the affected leg. The cast is removed and the extremity is numb and appears dusky and pale. Posterior tibial pulse cannot be appreciated. Passive manipulation of the foot causes excruciating pain. Which of the following is the next best step in the management of this patient? A. MRI of the left leg. B. Recasting. C. Open reduction and internal fixation. D. Fasciotomy of the left leg. Or E. Amputation below the knee. Okay. So the answer to this is D. Fasciotomy. So this is a patient with compartment syndrome, and we are very concerned here because if you don't treat compartment syndrome fast enough, you will wind up needing to do E, which is amputation below the knee. But what's happening here is we get a buildup of pressure. That buildup of pressure reduces the vasculation to that extremity, and the reduction of oxygenation to the extremity is what's causing the numbness, the dusky and pale appearance, etc. So what I want to point out here with compartment syndrome is, one, this is a major complication in orthopedic injuries. We always have to be concerned about this. Anytime we do anytime a patient has had a fracture, but particularly when they have a fracture and you do a closed reduction. Because when you're not looking at it, you don't necessarily know if you're messing anything up in there. For the most part, closed reductions are fine, but you have to keep this in mind as a possible complication. Now, there's 6 P's of compartment syndrome that are worth remembering. So pain, which is out of proportion to passive movement, paresthesia, pallor, paralysis, pulselessness, and poikilothermia, which is a fancy name for cold limb. This is particularly seen in forearm fractures, tibial fractures, and the infamous supracondylar fracture of the humerus that you see in kids. So these are the 3 of the fractures that you see this most in. Now, compartment syndrome is not always secondary to fractures. You can get it from other things. So you can see this in rhabdomyolysis. It's a major complication of rhabdomyolysis. You can see this in extensive muscle use, usually not the extensive muscle use that you would do on purpose, usually extensive muscle use from something like seizures. Drug and alcohol use, decreased serum osmolarity, DVT, and burns. If a patient has the classic symptoms of compartment syndrome and they have a typical history, which of course an orthopedic injury would be a typical history, then no extensive workup is necessary. You're going to want to get these patients off to a surgeon so that they can do a fasciotomy. And it's important to get them off as quickly as you can, because the longer it takes, the more likely the patient will actually wind up needing an amputation. So this is a fasciotomy, and I'm not sure, I think this is the leg, can't really tell. But anyhow, fasciotomy is just a cut. All you're doing is you're cutting the, it's going to be based on the surgeon, that they'll decide where to cut it. But they make this cut, and then usually what they do is they put in a sterilized gauze and a machine that generates negative pressure, and that pulls the fluid out, pulls the edema out, and that's called a wound vacuum or a wound vac. So these aren't exposed all the time, but this is just post-op from a fasciotomy. Okay, question 5. A 42-year-old woman presents to your clinic complaining of right foot pain. She says the pain has been going on for a few months now, but is coming in now because the weather's getting nicer and she wants to be able to go for walks. She says that the pain is worse when she wakes up in the morning, is centered around her heel, and nothing makes it better except for rest. However, it does tend to get less severe as the day goes on. On physical exam, you note pes planus of the foot, and you're able to elicit a stereotypic pain on palpation of the fat pad of the heel. Which of the following is the next best step in the management of this patient? A. X-ray of the right foot. B. Rest, ice, and orthotic support. C. Physical therapy and NSAIDs. D. DEXA scan. Or E. Fascial release surgery. Okay. The answer to this question is B. Rest, ice, and orthotic support. So this is a patient with plantar fasciitis. And the things that are typical of plantar fasciitis is this stinging pain, especially in your feet once you wake up. So it's always in the feet, but when you wake up, you get this pain in your heel, and it's always in the same part of your heel, right at the base of the calcaneus and more towards the anterior side. So this is your plantar fascia right here, which is on the plantar aspect of the foot. And right where it inserts onto the calcaneus is where you can get that inflammation. And that's simply due to the fact of how you move when you're walking. It puts stress on this plantar fascia, and that increases your risk for inflammation. Now, why are we not doing an X-ray of the foot? Because maybe there is a fracture or there's some kind of injury, and it's possible. However, because this patient has such a typical clinical history of plantar fasciitis, having the pain on the first few steps in the morning, having pes planus, so an abnormality of the curvature of the foot. Pes planus would be a flat foot. Pes cavus would be an overly arched foot. Those both put you at risk for plantar fasciitis. And that you get this stereotypical pain when you palpate her heel. Those all point towards typical plantar fasciitis. So you're going to go right on with the treatment. Rest, ice, and orthotic support. And within about 12 weeks, you should start to have some significant improvement. If you don't get any improvement, then it would be fine to go on to an X-ray. But because you have such an obvious case here, you will go right on to therapy. Physical therapy would not be as good as rest NSAIDs can be used for the pain, so in addition to rest, ice, and orthotic support, yes, you can use NSAIDs. DEXA scan would be something if we were considering that she had osteoporosis. That has nothing to do with this case. And fascial release surgery would be the last step in therapy for her. So if all else fails, fascial release surgery is what's done. But 90% of patients will respond to the rest, ice, and orthotic support for plantar fasciitis. Good to know about this one, even though most of you aren't going to be surgeons. I'm not a surgeon, obviously. This is a good one to know about because in the family clinic, if you're working as an internal medicine specialist, even perhaps if you're working with athletes, you will see plantar fasciitis. Okay, question 6. A 12-year-old boy presents to your clinic with his mother. For the past 3 months, his mom has noticed that he's been walking with a limp. The boy acknowledges that this is true, and he says that he has had some mild pain in his left leg, and that he has a bump that he thinks he might have gotten last summer playing soccer. On physical exam, you note a bony mass in his left leg, which is where the boy says the pain is located. Tibia fibular x-rays are taken and are as follows. So here's his Tib-Fib x-ray. Okay, I'll let you pause it here if you want to look at it. He was seen last 14 months ago for a sore throat, and his weight was the same that it is now. Which of the following is the most likely diagnosis? A. Ewing sarcoma, B. osteosarcoma, C. Pediatric onset multiple myeloma, D. Osteoid osteoma, E. Normal bone callus formation from previous injury. Okay. So the answer here is A, Ewing sarcoma. So Ewing sarcoma tend to be in the 5 to 15-year-old population, roughly. Osteosarcomas tend to be in the 10, maybe older teens to young adult population. And that's not as important as remembering as much as it is knowing how to acknowledge an x-ray. What is Ewing's sarcoma and what's osteosarcoma? With Ewing sarcoma, we get the onion skinning. And you can't really see necessarily a whole lot of the onion skinning in this one. But you definitely don't have the sunburst formations, which you would have in osteosarcoma. And so that's how you can kind of tell. Also, you do have something that you would see in both kinds of tumors. You have this Codman's triangle, which is this extension of bone formation that kind of forms this angle. That's a Codman's triangle. And this is in the fibula. All right. So the Ewing sarcoma is a malignant cancer, and this is likely why the boy's weight hasn't changed. So I kind of threw that in there. He's 12 years old. He was last seen 14 months ago. His weight hasn't changed. That possibly means he may have lost weight, but we don't know he lost weight because we haven't seen him in a long time. Kids who are young teens are usually gaining weight at a pretty quick pace. So if he hasn't gained any weight over the last year, then that may mean he's actually been losing weight. So this is a malignant tumor. It's usually in kids 5 to 15 years of age. We tend to see it on the diaphyses of long bones. So this would be a typical place for it to come up, the fibula. And or you could also see it in the tibia here. And it's this onion skinning pattern. The osteosarcoma is also malignant. It tends to occur in somewhat older children, younger adults, and it's most common at the distal femur. What you see here is the sunburst pattern. So much different than this onion skinning pattern. The osteoid osteoma, which I neglected to bring up on my pediatric bone tumor lectures, the osteoid osteoma is somewhat rare, but what you have with the osteoid osteoma is, first off, it's a benign tumor, so that's most important to remember. It affects both children and adults, but tends to be younger adults. And then it has a preponderance for the long bones, so has some similarities to the osteosarcoma, other than that it's not an osteosarcoma and it's not malignant. What you get with the osteoid osteoma that you notice on X-ray is a nidus, and this nidus is kind of this little eaten out part of bone, and that's this right here. This little area of demineralized bone is the nidus, and the nidus is not usually any more than 1.5 centimeters, so it's often quite small. This is a benign disease. So Ewing sarcoma and osteosarcoma are the two primary bone tumors that we see. They only happen in pediatrics, possibly very young adults. Secondary bone tumors are the tumors that we see in older adults. That could be multiple myeloma, affecting the bone marrow, or it could be metastasis to the bone. Question 7. A 32-year-old woman who is 30 weeks pregnant presents to your clinic complaining of intermittent pain in her left hand. She says she experiences episodes of pain, numbness, and tingling in her hand. Her pregnancy has been uncomplicated. On physical exam, you are able to reproduce the stereotypic pain by percussing over the ventral wrist with your reflex hammer. She says that the uncomfortable sensation is primarily over her thumb, index, and middle fingers. Phalen's test is positive. Which of the following is the best next step in the management of this patient? A. Splinting of the wrist at 20 degrees of extension. B. Splinting of the wrist at 20 degrees of flexion. C. X-ray of the left hand. D. Steroid injection into the left carpal tunnel. Or E. Surgical release of the transverse carpal ligament. Okay. The answer to this one is A. Splinting of the wrist at 20 degrees of extension. So this is a patient with carpal tunnel syndrome. Carpal tunnel syndrome has a huge female preponderance, roughly 3 to 10 to 1. So roughly between 70 to 80, 90% of patients with carpal tunnel syndrome are women. The peak age tends to be around 45 to 60 years of age. However, there is an increased incidence in pregnancy, and that probably has something to do with the increased volume and the edema, that mild edema that tends to happen with pregnancy. There's an increased incidence of carpal tunnel syndrome also in patients who have a higher BMI. What you'll see in carpal tunnel syndrome, first off, let me just familiarize you with the anatomy. The carpal tunnel is just this area between the carpal bones and this flexor retinaculum, otherwise known as the transverse carpal ligament, and under which through go several of the flexor ligaments and one important nerve, just one nerve, the median nerve. And this median nerve supplies sensory innervation to your thumb, your finger, pointer finger, and your middle finger. So, and those were the area of pain in this patient. If you go back to the question. So this is Tinel's test. This is the percussing over the ventral wrist that I was talking about, and this makes perfect sense as to why this would cause the pain. Look what goes right under your wrist, right here, your median nerve. You're basically percussing on the median nerve. When you have carpal tunnel syndrome, you have inflammation in this fixed kind of capsule area. And so you already have pressure on the median nerve. So if you're percussing it with a hammer, you're going to aggravate that median nerve and cause pain on the thumb, pointer, and middle fingers. So that's Tinel's test. Phalen's test is another good test. It's just also known as the reverse prayer position. And you just have the patient push their hands together in that position for a minute, and if the symptoms start coming on, that would be a positive Phalen's test. Another thing that you can see in carpal tunnel syndrome, particularly if it's gone on for a long time, is Thenar wasting. Now, this is obviously a patient who has it on both sides. Not all patients are going to have carpal tunnel syndrome on both sides, but here you can see that the muscle for the thumb, I think it's abductor pollicis, is very much smaller. And you can see the kind of loose skin over it. So an atrophied abductor pollicis. So Thenar wasting is another thing that you can see in a patient, especially if they've had chronic carpal tunnel syndrome. The treatment for carpal tunnel syndrome is splinting. What we want to do, though, is we want to make sure that we're splinting at 20 degrees of extension. And the reason for that is because during flexion, remember flexion, with the Phalen's test, you're aggravating the carpal tunnel. So extension is going to allow for the healing. So 20 degrees of extension. If this fails, then you can consider a surgical therapy, in which case we would actually just cut that flexor retinaculum. Question 8. A 15-year-old boy presents to the ED after suffering an injury at his school. He says that he was arm wrestling a classmate when he felt a crack and his entire arm gave out. He says that this was immediately followed by severe pain. On physical exam, you note that he is holding his right arm limp and there is a bony eminence about halfway down the upper arm, as well as some surrounding bruising. The fracture is not open. Humerus X-ray is ordered and shows. There it is. Okay. So here's your X-ray. All right. So which of the following is? Let's see. I'm make sure I don't not going on to. Okay, good. I just wanted to make sure I wasn't going on to the slide where I had the answer. All right, which of the following symptoms are most likely to be present in this patient? A, numbness over the thumb, pointer fingers, and middle fingers, and weakness of the wrist flexors. B, numbness over the ring finger and pinky, weakness of the wrist flexors. C, numbness over the dorsum of the hand, weakness of the wrist extensors. D, numbness over the lateral upper arm. Or E, numbness over the upper shoulder. All right, give you some time to look at all those. All right, and the answer here is C. So, this tests your knowledge of anatomy, and anatomy is important for step 2 and 3, as it's important for real life, even if you're not going to be an orthopedic surgeon. So what we have here in this injury is a humeral shaft fracture. We actually have a spiral fracture, and that's probably due to the fact that because he was arm wrestling, he was putting torsion force on his upper arm. But anyhow, regardless of what kind of injury it is an injury to the shaft of the humerus. And along the shaft of the humerus runs very intimately the radial nerve. As a matter of fact, when you look at the bone of the humerus, there's a region that's called it's the radial canal or radial notch. But anyhow, that's where the radial nerve runs. It runs very closely to the bone. So anytime you have a break to the shaft of the humerus, the radial nerve is very, 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 very endangered. So just from that, just from seeing that it was a humeral shaft break, you should know that it's going to be the radial nerve, and from then you can just look down the list and see which one of these is the radial nerve. So numbness over the thumb, pointer, and middle fingers, well, that's the median nerve. We just talked about the median nerve in carpal tunnel syndrome. The median nerve also supplies some of the wrist flexors. The ulnar nerve is over the ring finger and pinky, so that's your funny bone. When you hit your funny bone, you get your ulnar nerve sensation, and that's ring finger and pinky. And your ulnar nerve also is the prime supplier of your wrist flexors. The dorsum of the hand is primarily the region of the radial nerve. And then the wrist extensors are supplied by the radial nerve as well. So this is the right answer. Numbness over the lateral upper arm is the axillary nerve. That would be your regimental patch. You can see that in some dislocations. And then numbness over the upper shoulder, I don't know what that would correspond to, but that would be the supraclavicular nerve. In any case, it may be damaged. So this is a radial nerve damage due to a humeral shaft fracture. Classic injury. Definitely be aware of certain injuries and the nerves that they can correspond to. And in my upper extremity proximal lecture, I went over those in detail. A 38-year-old woman presents to the ER following a motor vehicle accident. She is screaming in pain, and she says that her hip hurts. Vitals are stable. On immediate examination, you note asymmetry of the hips, which, with the left iliac spine more superior than the right. The paramedics have already inserted 2 large bore IV catheters, and she's receiving a normal saline bolus. You have ordered IV hydromorphone for her pain. Pelvic X-ray is ordered. So your paramedics were doing their job. That doesn't always happen. Okay, and you did your job by getting her some pain relief right away, and now she can get her X-ray. Assuming she's stable. I didn't put that in here, but you can assume that. Okay, so here's the pelvic X-ray. Which of the following is the most common cause of death in a patient with this kind of injury? For you, a curveball here. A, septic shock. B, bowel entrapment. C, massive hemorrhage. D, fat embolism. Or E, deep venous thrombosis. So let's go back and just look at this again. Of course, you've got a massive pelvic injury. You're going to have your... This is a man, just to let you know. So this is not a woman's X-ray, but we'll just say this is what hers looked like. You're going to have your orthopedic surgeon coming down, running. All right, the answer to this one is C, massive hemorrhage. So with pelvic injuries, the number one, no matter what, the number one cause of death is hemorrhage. And that's because we have some major vessels down there. You've got your external and internal iliac, your common iliacs on both sides. You've got your abdominal aorta, which I don't think necessarily gets down that low, but all of those major vessels that supply your internal organs as well as your pelvic organs and your lower extremity are all down there. So you've got a lot of blood, and the blood pressure down there is much higher because with the veins, you're pumping upwards. So the blood pressure itself and the fact that you've got so many vessels down there both put you at risk for massive hemorrhage. And look at this. I mean, you got all these sharp bones pointing out in every which way. You could be in some major trouble. So massive hemorrhage is what we're most concerned about in a patient with this kind of injury. And that's why it's great that these wise paramedics inserted 2 large bore IV catheters, so if something were to go wrong, we were all ready to get her pumped up with fluids. Bowel entrapment can happen with pelvic injuries. However, it would not present a severe short-term cause of death. That would be something that may be 2 or 3 days later possible problem. Septic shock is always possibility in a surgical... I mean, all of these things are possible, but I just want to point out that massive hemorrhage is the number one cause of death in patients with hip injuries. Fat embolism would be probably I can't say this with certainty, but I'm pretty sure that fat embolism would be the #1 cause of death directly attributed to like a injury to like the femur. All right. Question 10. A 63-year-old man presents to your clinic complaining of mild pain and stiffness in his hand. He says over the past few months he has noticed that it has become more difficult to open bottles, grasp objects, and most importantly, throw the tennis ball to play fetch with his German Shepherd dog. He is otherwise in excellent health. On physical examination, you note bilaterally nodules on his palms, along with intermittent pits and fibrous cords along his flexor tendons. He's not able to lay his hands flat upon the table. Which of the following is the best treatment for this patient? A. Surgical fasciectomy. B. Hand physiotherapy. C. Steroid injection. D. Botulinum toxin injection. Or E. TNF inhibitors. Okay, and the answer to this question is A. Surgical fasciectomy. So this is a patient with Dupuytren's contracture. And Dupuytren's contracture is typically seen in older men, especially of Scandinavian descent. Now, I don't know to which extent that matters to you, but for me, I practice in Minnesota, and we have a lot of Scandinavians in Minnesota, including myself. So just for that fact, we see this often. And so with Dupuytren's contracture, what you've got is just this chronic inflammation and contraction of the palmar fascia. And over time, this contracts and it draws the fingers closer to the wrist. And what you'll also see are these little nodules too. Another thing that's very typical of Dupuytren's contracture that you don't see is you don't see much of these symptoms, these pits and nodules and cords on the thumb or the pointer finger. That part tends to be spared, but the 3rd, 4th, and 5th digits are very much affected. So surgical fasciectomy is going to be how we treat this. And I will say that usually the point where we decide that surgery is the treatment is when the patient either they're having severe difficulties in their daily life or they can't lay their hands flat upon the table. Usually if you can't lay your hands flat upon the table, it's going to be difficult to do most things. But surgical fasciectomy is the best treatment for Dupuytren's contracture. And here's a Dupuytren's contracture. So here you can see a nodule here, a nodule here, a nodule here, 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 here. This is just a mild case. And you can see there's really nothing around the thumb, pointer finger. Maybe this is a nodule. Here's a quite severe case. So now you can see this has gotten actually so bad that this man's middle fingers have actually been pulling into that position. His pinky's been pulling into this position. So this is very severe. You can see some nodules here. You also see the pits, which are just the areas in between the nodules. You can't really see fibrous cords here, but you know that this is Dupuytren's contracture because you're getting that typical contraction of the fingers. And this is a Dupuytren's contracture status post fasciectomy. And what they do is they just surgically repair the fascia. This is immediately post-op or a few days post-op. And this is afterwards. So you can see a little scar there, but the hand is fully functional. Surgeons can be our friends sometimes. I'm just kidding. All right, I think that's all I got for you for this section.